Welcome everyone to the Canadian Nurses Association webinar series, Progress in Practice. This webinar is about advanced practice nurses' role in opioid stewardship. This session is being recorded for nurses who are able to attend or participate today. My name is Chantal Bailey. I am a Health System Impact Fellow at the Canadian Nurses Association and the University of Toronto, and I'll be presenting this webinar. At the end of the presentation, we will answer your questions, which you can type in the Q&A box that you will see at the right-hand side of the slide. We will address as many questions as time allows. The certificate of participation will be emailed to you, along with the link to the recording of this webinar. Okay, next slide. So why opioids? We know that there's an ongoing pan-Canadian opioid crisis. 6 million people in Canada, that's approximately 19% of the Canadian population, report some form of pain, and opioids can be used to treat moderate to severe acute pain. Canada is the second largest consumer of prescription opioids. Inappropriate prescribing can lead to opioid-related harms, including opioid use disorders, neonatal abstinence syndrome, and other adverse effects, such as CNS and respiratory effects. The rates of opioid-related overdoses and deaths continue to increase. So although my slide says that there have been approximately 10,300 apparent opioid-related deaths, the Public Health Agency of Canada released new figures last week, which shows that there has been more than 11,500 apparent opioid-related deaths between January 2016 to December 2018. There were 4,460 deaths in 2018, which equates to one life being lost every 2 hours. Most of these deaths occurred among males and involved fentanyl and fentanyl analogs. Next slide, please. So in terms of the current rates of opioid-related deaths, here we can see that there's been a steady increase in deaths between 2016 to 2018. That is from 8.4 to 11.8 per 100,000. However, as I mentioned before, the Public Health Agency of Canada released updated figures on these death rates. Next slide, please. So in national and regional trends of apparent opioid-related deaths, so here we're still looking at deaths, we see that the opioid crisis is having a serious effect across Canada, with BC and Ontario having the highest rates. These estimates on annual death rates were calculated on available data at the time on the unintentional opioid-related deaths. Next slide, please. So just quickly look at the federal strategy for addressing the opioid crisis. They are utilizing a public health approach with 5 focus areas. The first area is access to treatment. They remove regulatory barriers to allow nurses to transport controlled substances. They've enhanced the delivery of culturally appropriate substance use treatment and prevention services in First Nations and Inuit communities. For access to harm reduction, they've approved more than 25 supervised consumption sites and supported regulations to protect individuals who seek emergency assistance for overdose. Next slide, please. For awareness and prevention, they supported and are supporting the development of opioid prescribing guidelines and national treatment guidelines for opioid use disorders. And they've devised a multi-year campaign and other continuing efforts to expand public awareness around stigma. For the tainted drug supply, to address the tainted drug supply, they've equipped border agents with tools to intercept fentanyl and other dangerous substances at the border, supporting education and training for law enforcement. So in terms of generating evidence, they're coordinating a national data collection strategy, and they're publishing quarterly reports on apparent opioid-related deaths and harms. They intend to increase the understanding of Canadians' knowledge of opioids and associated risks, and establish a pan-Canadian pain task force to assess best and leading practices that could improve the prevention and management of chronic pain in Canada. So now let's look at the concept of stewardship. Next slide, please. So in terms of stewardship, it can be defined as a patient-centered, interdisciplinary approach for optimizing drug therapy. I actually thought before I start discussing opioid stewardship, it would be actually a good idea to discuss antimicrobial stewardship, which is a proven model for effective antimicrobial prescribing. So, for example, antimicrobial stewardship can be defined as coordinated interventions designed to improve and measure the appropriate use of agents by promoting the selection of the optimal drug regimen, including dosing, duration of therapy, and also route of administration. So in terms of hospital antimicrobial stewardship models, they've been shown to be effective in reducing nosocomial infections, so the C. difficile and MRSA, unnecessary exposure to antimicrobials, antimicrobial resistance rates, and healthcare costs associated with treating infections. Now, these interventions can be classified as restrictive, persuasive, and structural. For example, restrictive interventions include restriction or removal of war stocks and pre-approval. Persuasive interventions include audit with feedback and education. Also, structural interventions can include rapid susceptibility testing. Next slide, please. But although the registered nurse's role has not been formally recognized in guidelines for implementing or operating antimicrobial stewardship programs, or defined in the peer-reviewed literature, nurses have always performed numerous functions that are integral to successful antimicrobial stewardship. Next slide, please. So, for example, the American Nurses Association back in 2017 highlighted the unrecognized role of nurses and antimicrobial stewardship functions. For example, progress monitoring, where the nurse cares for the patient 24/7 and monitors and communicates daily patient progress. In terms of antimicrobial dosing, culture and sensitivity reporting and de-escalation, nurses update clinical and laboratory renal function results, for example, drug levels and preliminary and final microbiology results in the patient charts. In terms of patient education, nurses continue to educate patients and their families around antimicrobial therapy and also perform discharge teaching as well. Next slide, please. So I thought I will highlight one of the studies around antimicrobial stewardship before we move on to opioid stewardship. So a study that examined a nurse's knowledge, attitudes, and practices regarding antimicrobial stewardship. This study was conducted probably back in 2016, published in 2018, and was conducted in a quite large academic health system. And some of the key findings were that nurses were unfamiliar with the term antimicrobial stewardship. Of the nurses who correctly identified the correct definition, 89% felt they actually had a role in antimicrobial stewardship, which is fantastic. Okay. And also, they desired to learn more about their roles in antimicrobial stewardship, and that was 97%. So this study highlighted certain enablers around antimicrobial stewardship. They said, for example, the nurse said, well, if they have discussions with prescribers and or the prescribing team regarding antimicrobial orders, that'd be really helpful in terms of dosing, route, appropriateness of therapy. And also some barriers were highlighted as well. And those included sort of, for example, lack of knowledge of antimicrobials, lack of time, and challenge that if there were any challenges to antimicrobial therapy, that sometimes they would not be received very well by prescribers. Next slide, please. So let's move on to opioid stewardship. So opioid stewardship, there are several definitions I found, but one of the definitions provided here is that it's a coordinated intervention, so not dissimilar for antimicrobial stewardship, designed to improve, monitor, evaluate the use of opioids in order to support and protect human health. There are other definitions provided in the literature as well. For example, coordinated effort is a coordinated effort to promote the use of opioids, improve patient outcomes, reduce misuse and abuse, and decrease patient morbidity and mortality attributed to these high-risk medications. Next slide. So the National Quality Forum in the US, they produced 7 core components of opioid stewardship. So one of the core components that they propose is leadership, commitment, and culture, which includes allocating resources and support for organizational leaders. Having that senior leadership support for your stewardship programs is highly essential to their efficacy. In terms of organizational policies, they said these should be developed to support evidence-based approaches to multimodal pain management. Another core component was clinical knowledge, expertise, and practice. They ensure that clinicians are trained in and understand the science of pain, evidence-based pain management strategies, and also utilizing effective patient communications techniques and strategies. Another core component was community collaboration. They said, well, actually, this is actually quite effective for stewardship, not only in acute care, but primary care, and also in other healthcare contexts. Next slide, please. So the other core component was patient and family caregiver education and engagement. They said that this is actually very, very important because it ensures that they want to make sure that patients are fully informed about the risks and benefits of appropriate pain management options and are active participants in decisions about their pain management plans. So that's around shared decision making. Another core component was tracking, monitoring, and reporting. And that could be looking at your opioid prescribing rates, looking at patient-reported outcomes, adverse events, and the use of prescription monitoring programs that identify opportunities for improvement and assess the impact of opioid stewardship efforts in your healthcare organization. So in terms of accountability, to articulate clear expectations for creating, promoting, and maintaining a culture of opioid stewardship. Next slide, please. So we can see that opioid stewardship interventions are targeted at the organizational level, at the nurse or health provider level, and at the patient level as well. So for example, at the organizational level, you can have prescribing standards, policies, and guidelines. At the nurse or health provider level, you can have adherence to those policies and guidelines embedded into practice. And in terms of patient level, targeted interventions, looking at patient education and counseling, which will hopefully promote or improve adherence to prescribed opioid regimes. Next slide, please. So actually, this will give you a quick overview of my research program, which is focusing on the roles of nurses in opioid stewardship. So the study aim and the research questions were, firstly, let's look at the aim. The aim is to support the development, implementation, monitoring, and evaluation of nurse-led or driven stewardship interventions. Why? So nurses are the largest group of point-of-care health providers in Canada, and they're actively involved in the prescribing pathway and are ideally placed to contribute significantly in optimizing stewardship interventions. And also like to generate evidence regarding nurses' roles, well, more evidence regarding nurses' roles in optimizing opioid therapy. So my key research questions were, what are the roles of advanced practice nurses and RNs in managing opioids? Are they new and emerging roles? And how can these roles be optimized? But before I go into that, I thought I would give you I thought this was actually interesting, the prescribing pathway. And you can see that there are about 5 or 6 major actors. You have your patient, you have your prescriber, you have your nurse, you have your clerk and technician, and also your pharmacy as well. But then you see that the nurse is central. You know, they are the key link between patient and health providers within the opioid prescribing pathway, and they're central to decision making and care processes as well. Next slide, please. So before I started conducting research in clinical care settings, I actually think it would have been a very good idea to see what those regulatory perspectives are. So next slide, please. So first, I looked at the Canadian Council of Registered Nurses Regulators, which is a national forum and voice regarding interprovincial, territorial, national, and global regulatory matters regarding nursing regulation. And they're composed of 12 provincial and territorial nursing regulatory bodies. Now, these nursing regulatory bodies, as you know, are responsible for setting entry to practice competencies, establishing standards of practice and licensure requirements, approving entry to practice and educational programs, and also establishing continuing competency requirements for nurses. Next slide, please. I found this key publication, which actually says, it's entitled The Role of the Nursing Regulator in Safe Controlled Drugs and Substances Prescribing and Harm Reduction. And they propose that the nurse regulatory body should focus on 6 key areas around controlled drugs and substances. And these 6 focus areas are controlled drugs and substance prescribing for nurse practitioners, entry-level and remedial education on prescribing competencies for nurse practitioners as well, education and practice with respect to harm reduction, utilization of electronic pharmacy management e-systems for supporting medication reconciliation, monitoring of prescribing and quality assurance, and also entry-level competencies for registered nurses, including ways to support effective pain management and limit abuse potential. So I conducted a narrative review of publicly available policies and guidelines related to controlled drugs and substances and also opioids, and that were produced by nurse regulatory bodies, including scope of practice, standards of practice, and also other relevant documentation as well. I conducted this review between January to September 2018, and the data was analyzed using endeavours just to identify what are those emergent themes and sub-themes. Next slide, please. So here's the overview of some of the emerging themes. Next slide. So in terms of core principles, not surprisingly, when you look across the policy documents produced by nursery regulatory bodies, medication safety was core, and also medication management were core principles. So medication safety, as we know, is defined as freedom from preventable harm with medication use. And medication management is patient-centered care that optimizes safe, effective, appropriate drug therapy through collaboration with patients and their healthcare teams. And required knowledge for medication management, medication safety, again, looking at those principles of medication safety, looking at those human factors that may impact medication safety, looking at those limitations, again, with medication systems, and also best practices to reduce medication errors and near misses. So medication management, this is a busy slide, but these are some of the key principles that came out around medication management that are actually quite relevant for opioid prescribing. Assessing the appropriateness of a medication for the client based on the health status or condition, upholding the client's rights in the medication process, information on allergies and sensitivities where appropriate, performing medication reconciliation at care transitions, knowledge of actions, interactions, usual dose, route, side effects, and other adverse effects associated with the medication, knowledge of correct dose calculations, for example, using drug dose calculators and drug libraries, preparing the medications correctly, obviously documenting, educating clients on the management of their own health, including fully informing them about their medication, any sort of anticipated effects, side effects, drug interactions, contraindications, self-administration, treatment plans, and follow-up. Monitoring the client before, during, following medication administration, managing side effects and adverse effects of the drug, and evaluating the effect of the medication on the client's health status. So these are some of the key components of medication management. But another key component of, next slide please, of medication management is medication administration, which is defined as preparing, giving, and evaluating the effectiveness of prescription and non-prescription drugs. And there are several rights in medication administration. So it's right client, right medication, right dose, right route, right time, right reason, and central to all these activities is right documentation. Some other organizations refer to the right to refuse, for the patient to refuse therapy, right assessment or evaluation, and also right education as well. Next slide. So here are some of the identified themes I found in the policies, and I'll just give you a high-level overview of each theme. So, not surprisingly, there was substantial overlap with the 7 core components of opioid stewardship that I described earlier. For example, clinical knowledge and expertise in practice, tracking, monitoring, and reporting, and patient and family care education and engagement. These themes or roles of advanced practice nurses or registered nurses where appropriate are integral to effective opioid stewardship, although they go often recognized as within antimicrobial stewardship as well. So looking at patient assessment, there are three major categories, and that was pain assessment, risk assessment, and prescribing with opioid agonist therapy. So in terms of patient assessment, looking at pain severity and intensity, conducting those pain assessments, utilizing appropriate methods or tools, such as the PQ or RST method for assessing pain, which looks at provocation or palliation, quality and quantity, regional radiation, severity scale, and timing of pain. And also ensuring that those pain assessments are conducted in person. In terms of risk assessment, incorporating those evidence-informed strategies for assessing, managing, and monitoring the risks of misuse, addiction, and opioid diversion. How do you identify patients or clients who are at risk of these factors, of these issues? Appropriate use of risk assessment tools, such as the opioid risk tool, and prescribe a minimum amount while balancing client needs and risks of harm. For prescribing opioid agonist therapy, such as methadone, you have to confirm those diagnoses of the opioid use disorder using DSM-5 criteria, for example. Reviewing the medication profile and medication history using prescription monitoring programs where available. Access to other substance use disorders and or concurrent use of substances such as alcohol, benzodiazepines, and other sedative hypnotics. Developing that treatment plan in collaboration with the patient, and also promoting client and public safety, where you prescribe, for example, a daily witness ingestion until the client has sufficient clinical stability and is able to safely take home carry doses of the methadone, for example. So for the medication reconciliation, really trying to get that best possible medication history. And that can be done by utilizing a systematic process for interviewing the families and the patient as well. They suggest that you review at least one reliable source and other reliable source to obtain information and verify all of the patient's medications use. And that includes prescribed and non-prescribed drugs. So you have your over-the-counter drugs, complementary and alternative medications. And I've seen some people, when they've done the best possible medication history, have also asked patients about the nutritional supplements that they're currently taking. So utilizing this approach of medication reconciliation, that enables accurate and comprehensive communication, particularly across care transitions and at key transfer points as well. So for prescribing, which is another theme, this is a massive theme, not surprisingly, complying with the applicable legislation, regulations, and standards and guidelines, knowledge of relevant sort of federal, provincial, territorial drug schedules, prescribing within that current therapeutic relationship, utilizing medication therapy trials where appropriate with or without adjuvant therapy, and based on the client's preference, utilizing those shared decision-making strategies. And shared decision-making came through in a lot of these themes, a lot of the roles that nurses actually do. Next slide, please. So in terms of treatment plan, which, monitoring, evaluating, or revising the treatment plan or the plan of care of opioid therapy based on evidence-informed practice, and also the client's goals, as I mentioned before, that shared decision-making, preferences, health status, and outcomes. So that can involve pharmacological or non-pharmacological options, looking at those risk-benefit profiles. But the key thing is also to ensure that the patient confirmed and ensure that the patient understands the treatment plan, which is set to improve adherence. So for medication orders, they can be our directions provided by the prescriber for a specific medication to be administered to an individual, and they can come in multiple formats. You have that verbal orders, telephone orders, paper-based orders, electronic orders as well. I want to review the standards relating to medication orders. They say that the medication order should specify in whatever format, whether it's a verbal order, paper-based, or electronic order, the client's name, the full name, the order date, medication name, strength, dose, start date, stop date, route of administration, frequency, the prescriber's name, signature, designation, clinical indication, and also monitoring requirements as well. And they were suggesting that when you're prescribing the opioids, be cognizant of those medication abbreviations and symbols, especially for those drugs that, they could sound alike or look alike. Next slide, please. So medication administration was actually another main focus of multiple policies. So, we've had medication administration is defined as preparing, giving, evaluating the effectiveness of prescription and non-prescription drugs, utilizing those several rights of administration. For example, right client, right medication, right dose, right route, etc., as I mentioned previously. And as I said, not surprisingly, this is the main focus of multiple policies because it's so core to the role. So although there are multiple types of medication administration, for example, procedural sedation and analgesia, it is important to know that adherence to medication schedules and times is actually quite important. Other sub-themes were highlighted, such as informed consent procedures, and also the use of 2 client identifiers and independent double checks should be utilized prior to administration, particularly for high alert opioids, such as intravenous, transdermal, and oral opioids that have liquid concentrates or immediate and sustained release formulations. So in terms of medication preparation, selecting, mixing, calculating doses where appropriate, using those sort of like the accepted techniques, adhering to dispensing standards, policies, and procedures. In terms of dispensing, again, looking at those policies and procedures, utilizing medication supply systems, for example, stock supply, unit dose, and automated dispensing. And transcribing was quite important too. Paper-based, using paper, whether the medication order is paper-based or electronic, where you have to transcribe that information onto the medication administration record. Just make sure that it's been validated for accuracy and completeness as well. So those are other themes that came out. Next slide, please. So in terms of monitoring therapeutic responses, this can involve repeated or continuous observations or measurements of patients, their physiological functions, etc., that guides opioid management decisions and includes, as I said before, therapeutic response monitoring, identification of any sort of undesired responses. And then based on this, it may be decided to adjust opioid therapy, whether you continue, taper, or titrate, or discontinue therapy, and ensure that all these, whatever decisions are made or whatever drugs are administered, that any changes are documented in the patient record. For effective monitoring, some policies recommended that that they should be an opioid pharmacology knowledge base, which includes, for example, pharmacodynamics, pharmacokinetics, knowledge of opioid-related adverse drug events, so adverse drug reactions, allergies or intolerances, knowledge of suboptimal dosing and overdosing, drug-drug interactions, and any sort of contraindications of opioid therapy as well. So reporting, which could be internal, that is within the healthcare facility, or external to MedEffect, Several terms were used to describe what should be recorded and reported by nurses, such as safety event reporting, incident reporting, harmful incidents, and no harm incidents related to opioids. Most policies were focused on reporting medication incidents, errors, near misses, and also some policies highlighted reporting of opioid diversion by patients and also other members of staff. Some policies suggested that drug therapy problems should be reported as well, and that drug therapy problems could be defined as sort of like that undesirable event experienced by a patient that involves or is suspected to involve opioid therapy and that interferes with achieving the desired goals of therapy and requires clinical judgment to resolve. So in terms of recommended reporting systems, some say, well, actually use your hospital incident reporting system. And then also some policies recommended as well reporting to Medifact. And if you're going to report to Medifact, report adverse drug events and any other sort of drug therapy problems. Next slide, please. So medication inventory management was another key finding. And this is core to the nurse's role as well. So inventory management is to be executed in a manner which protects patient safety through the identification and disposal of outdated, deteriorated, recalled, or obsolete controlled drugs and substances using the most appropriate methods. This may include making sure that systems are in place to track the movement of controlled drugs and substances, including opioids and other medications, between and among the pharmacy and the ward and other remote dispensing locations as well. In terms of safe handling and storage, transport, and disposal and wastage, it does not only apply to controlled drugs and substances management, but also to prescription pads, making sure that your prescription pads are kept safe. Some policies highlight that healthcare facilities also have a role in medication inventory management, which includes creating or maintaining policies and procedures that ensure medication inventory management that specifies conducting those medication inventory audits and reconciliations, reporting the processes or audit and reconciliation results, making sure that there's a reporting system to record and report results to key stakeholders, ensure that there's environmentally safe and secure disposal for controlled drugs and substances, and ensure that there's up-to-date inventory of controlled drugs and substances as well. Other organizational responsibilities included provision of an organizational infrastructure, quality assurance mechanisms, and ensure adherence to Health Canada legal requirements related to the custody and possession of controlled drugs and substances. And the policies were suggesting that whether you're an advanced practice nurse or a registered nurse, you should be aware of those requirements, Health Canada requirements. Next slide, please. When it came to patient education and counseling, this can be done during admission and at discharge. Again, a key component of opioid stewardship. Therapeutic education, patient education should enable patients to acquire and maintain abilities that allows them to optimally manage their lives with pain. It's a patient-centered and organized awareness, includes organized awareness, information, self-care learning, and also psychosocial supports regarding pain, prescribed treatment, and care as well. And as I said, they can occur during admission or at discharge, or both. Ensure that patients understand their discharge medications, and this will help to identify or resolve any potential barriers to medication adherence. When I looked at the standards for patient education and counseling, these included ensure that the patient understands the indications for use, expected opioid therapeutic effects, management of potential adverse effects of withdrawal symptoms, what to do, how to identify them, and then what to do if they're experiencing any adverse effects of withdrawal symptoms from their opioids. Interactions with other drugs and substances, caution them about that. Precautions specific to the patient. If you have identified any other specific barriers to medication adherence, really addresses precautions specific to the patient. That will be probably actually quite patient specific. Adherence to prescribed regimes, safe handling and storage, and required follow-up. And some of the policies really advocated and suggested that adherence to prescribed regimes around opioid therapy is actually really, really important. So is safe handling and storage, particularly in the home, really trying to limit access to other individuals and avoid opioid diversion. Next slide, please. So that was patient education and counseling. When it came to the education for nurses, they said that education requirements to optimal controlled drugs and substance prescribing, including opioids and opioid management, for example, require, again, looking at those, having a knowledge and awareness of relevant federal, provincial, territorial legislation and requirements and regulations, looking at those standards and policies, being aware of those, using the appropriate screening and assessment tools, having the knowledge to how to use those tools effectively, not only looking at pharmacological options, but non-pharmacological options for pain management, having a knowledge base around pain pathophysiology, and also opioid tolerance, dependence, opioid use disorders, and opioid diversion as well. But ensure that you understand that I have knowledge of the appropriate guidelines for these conditions as well, and and the reporting infrastructure, and how to recognize opioid diversion. I have listed some areas which is highlighted in the policy around nurse education. It was, again, as I said before, the pain management and assessment strategies, looking at that biopsychosocial model of care. Some policies said actually, trauma-informed care, the principles of harm reduction, how to destigmatize addiction, and also be able to refer patients to the appropriate community supports as well. So, advanced practice nurses and registered nurses have a specialized body of knowledge and are uniquely positioned to take a role or a leadership role in opioid safety initiatives, research, policy and development, design, and implementation of policies as well. So in the literature, that was just looking at nurse regulatory bodies. But I actually thought, let me start looking at religion and see if there's any barriers to the nurse's role in opioid stewardship or managing opioids in different healthcare settings. So in terms of patient-level barriers, one barrier that was in the literature was assessing pain in patients with language barriers can be a significant barrier, and or if they have compromised communication skills, such as sensory or cognitive impairment, such as patients with dementia. Some of the literature highlighted negative attitudes and beliefs around pain medications, inadequate patient communication of pain experiences to healthcare professionals. If the patient is unable to communicate their pain effectively to the healthcare professional, that can be a barrier as well. One or two studies highlighted shared decision-making or patient preferences were not considered, and they say that that was a significant barrier. Parental resistance to opioid use, for example, in pediatric populations, due to concerns about adverse effects, tolerance, and addiction. Another patient-level barrier was poor adherence prescribed regimens due to poor tolerance if the patients are unable to tolerate opioids. That is a major barrier. And also, for example, if the patient experiences any sort of adverse drug events, for example, drowsiness or constipation as a result of taking opioids. In terms of nurse-level barriers, they said in the literature that attitudes and beliefs may lead to conservative pain management. For example, they said, some nurses believe that opioids can be dangerous, and as I said in the previous slide, may lead to addiction or abuse. Some literature specify that insensitivity to pain experiences in the elderly was a barrier. Disagreement with pain assessments conducted by other healthcare providers was a barrier as well. Equating the absence of self-reported pain with the absence of pain. Inadequate education and training had a major impact on sound clinical decision making regarding pain therapy. That was another finding in the literature. And awareness of national and local pain guidelines and policies. And then if these guidelines and policies, prescribing policies, opioid management policies have been updated, where the updates were not necessarily communicated and they were not aware of certain updates that were relevant to their scope of practice. This is whether they were advanced nurse or registered nurse. Next slide, please. So in terms of nurse level barriers, when I looked at literature, certain knowledge gaps were identified. So some of the knowledge gaps, again, these are other barriers that were highlighted around pharmacotherapy, you know, medication types and selection, appropriate prescribing. Pain is so subjective. So, you know, determine those indications for opioid therapy and then having an awareness of those contraindications as well. You know, dosing, titration, and weaning protocols, equivalency and substitution, looking at adverse drug events and reactions. Again, that was another barrier that was highlighted. In terms of jurisprudence, being aware and having knowledge of laws and regulations that affects your scope of practice. What's the liability or accountability around opioid prescribing, particularly in pediatric populations? Is there sort of regulations around the use of prescription monitoring programs? When is it mandatory? When is it optional? Looking at those nurse regulatory standards, and also what are the documentation requirements? What should be legally documented in the patient record? So for safety and risk management, which is identified as another knowledge gap, you know, how do you identify aberrant behaviors, misuse of opioids, double doctrine, opioid diversion, you know, around clinical and management of aberrant behaviors. As I mentioned before, safe prescribing, adverse drug events, reactions, and how do you identify populations that are at risk? Which populations are more vulnerable than other populations? And again, this came out more around prescribing in the pediatric populations. Next slide, please. And then other gaps knowledge gaps were identified in terms of comprehensive treatment planning. Monitoring, what are those treatment alternatives? Not only looking at the pharmacological options or the opioid option, but looking at non-pharmacological options as well. Optimizing clinical decision making when making those care plans or treatment plans. You know, providing optimal education to the client or the patient. What is how much information do you give to your patients and how much do you not give to your patients? That was a major concern or major knowledge gap. Consultation, when do you consult, when do you not consult, and also identifying other clinical supports when prescribing. Risk-benefit analyses, informed consent procedures, developing those treatment agreements, and then coverage and benefits related to opioid therapy and other pain management medications. In terms of evidence-informed resources, knowledge of those clinical practice guidelines, what are those clinical policies, not only within their organizations, but other in external to their organizations as well. Other tools and resources that can be used in pain management. Again, that was another knowledge gap that was highlighted in literature. And then the other knowledge gap that was highlighted in literature was those ethical considerations. You know, the fear of risks of opioid prescribing that may inhibit whether to initiate the opioid or not. So based on that and building on that knowledge, I'm about to conduct some research around looking at the analysis of opioid-related safety reports, looking at medication errors and incidents, near misses, discrepancies, using the National Coordinating Council for medication error reporting and prevention, index of medication errors, and I might use other thematic frameworks as well. I really want to understand where should opioid stewardship interventions be targeted. So I believe that the opioid-related safety reports will give me an indication, whether is it administration, whether it's documentation, whether it's suboptimal dosing, etc. Really having a clear understanding of opioid-related safety reports and what that story that is telling us about opioid interventions and the role of nursing and etc. And then in phase 3, I will be conducting clinical ethnography, really trying to find out the workflow and process mapping of both advanced nurses and registered nurses, utilizing, as I said, ethnographic methods to obtain an in-depth understanding of the scope of practice of nurses in opioid stewardship. I really want to understand the workflow in assessing, diagnosing, prescribing, and managing patients of opioid analgesics. I want to understand those interacting, which care processes enable and which care processes limit optimal opioid therapy. So looking at those interacting and divergent care processes, care pathways, and also looking at the clinical microsystems as well. Looking at the care team, the model of care around managing opioids. Next slide, please. So I just wanted to acknowledge my funders is the Canadian Nurses Association, the Canadian Institute of Health Research and MITACs, and also my supervisors, Mr. Michael Villeneuve and Dr. Leon Jess from the University of Toronto and Mount Sinai. So before we move on to the Q&A period, we would like to ask questions of the participants. So we'd just like you to answer a couple of questions about today's webinar. Okay, thank you so much for your responses. We will now start the discussion portion of the webinar. If you haven't already, please type your questions into the Q&A text box. Okay, we received one question, for example, is there effective education to patients about appropriate pain control, and how do we feel that we need to fill this gap? Is there effective education to patients about appropriate pain control? From literature, that was one of the key. Yeah, patient education was quite a tricky one. There's that tension between how much information do you give to your patients? Some patients want to be fully informed of the opioid therapy, its risks, its benefits, what to do if they're experiencing any sort of withdrawal symptoms, if they're experiencing any sort of adverse drug effects, adverse drug reactions. And then some patients, they actually just want to take the medication and take it as they need it. So it's actually a very, very tricky one to answer. But what we have done, we've set up sort of like a patient engagement team as part of our stewardship committees, and they provide valuable insights into what they want to know in terms of when they're in hospital, what they want to know. Also as well, at discharge, what they need to know. And I think sometimes what I'm hearing from patients is that sometimes they struggle with, actually, I do have a question about my opioids, who do I speak to? Sometimes they actually go to the community pharmacist where they just pick up their prescriptions. but sometimes they want to talk to other healthcare providers. So it's ongoing learning for us. But I think engaging with patients, trying to understand what they want to know is very, very important, and being aware of any sort of standards around patient education and counseling as well. How do we apply these concepts in situations where the individual is suffering from addiction? So that's a very, very good question as well. The challenge with opioid prescribing sometimes is identifying those concurrent substance use disorders. So again, I'll refer back to, go back to the policies, the guidelines around managing pain, and see what they say around which ones do you treat first. I think there are actually some guidelines around managing pain for patients who have concurrent substance use disorders, but also those as well who have concurrent mental health conditions as well. So there are actually policies and guidance out there that be able to help you treat patients, but it is actually a very, very good question. Okay, so someone says, I want to make a comment regarding patient and family education. This not only occurs during admission and discharge. In practice, or at least in my practice, every contact with a patient and a family is a potential motivation. Absolutely, creating those learning opportunities and optimizing and capitalizing those patient engagements to facilitate patient education and counseling is absolutely fantastic. And absolutely, yes, that's a very good point. Thank you so much. So we hope that this session stimulated your thinking about opioid stewardship, understanding that the roles generally go unrecognized in policies and guidelines and sometimes in literature, but advanced practice nurses and registered nurses conduct those activities that are key and central to effective opioid stewardship within healthcare facilities. You can access recordings of our webinars by visiting CNA's YouTube channel. Next slide, please. And this fall's webinars will be announced in August. Thank you so much for your participation today, and goodbye.